Welcome to this comprehensive guide on hypertensive crisis, which is a medical emergency that affects millions of patients worldwide. In this video, we are going to explore what it is, how it is diagnosed, and step-by-step management strategies. Whether you are a patient, caregiver, or a healthcare provider, understanding this can save lives. Let us begin. Hypertensive crisis occurs when blood pressure elevates dangerously high, where we have a systolic blood pressure of equal or more than 180 millimeters of mercury and or diastolic blood pressure of equal or more than 120 millimeters of mercury. This can damage key organs of the body like the heart, brain, kidneys, and the eyes if they are not addressed quickly. It's not just about the numbers, it's about the risk to the body. Upon the patient's arrival at the healthcare facility, the process begins with the patient's registration to gather their basic information such as the name, age, gender, location, and medical cover. After that, the patient is taken to the triage area where there is measurement of their vital signs such as the blood pressure, the pulse rate, oxygen saturation, respiratory rate, temperature, body mass index, and abdominal circumference. Then the patient is taken to the consultation room where a detailed history is taken of the symptoms, medications, and their adherence, family history, and then a thorough physical examination follows to rule out signs of end organ damage. Once hypertensive crisis is suspected in a patient, the initial workup should focus on identifying acute end organ damage to distinguish urgency from emergency. The tests that you are going to do should be guided by the patient's symptoms and physical exam findings and not routinely for every case, so as to avoid unnecessary procedures while quickly ruling out life-threatening complications. For the initial workups based on patient symptoms, order lab tests like complete blood count, urinalysis, urea electrolytes and creatinine levels, liver function test, troponins, creatinine kinase myocardial band test, pregnancy test, lipid profile, random blood sugar, and HbA1c. For the imaging studies, you can order for the ECG, echocardiogram, abdominal ultrasound, point of care ultrasound, chest X-ray or chest CT scan, head CT scan, or brain MRI. Hypertensive crisis is classified into two types: asymptomatic or hypertensive urgency, where there is no immediate end organ damage despite the higher blood pressures. And then we have symptomatic or hypertensive emergency, which involves acute damage to the key organs of the body like the brain, heart, or kidneys, and it requires immediate intervention. This classification will guide the treatment plans. Hypertensive urgency is managed as an outpatient therapy using oral antihypertensives to slowly reduce the blood pressures over 24 to 48 hours with close monitoring. This is done to avoid medically induced complications of tissue hypoperfusion. For outpatient management, either uptitrate existing oral antihypertensives or start or restart them, especially for those patients who are non-adherent to their antihypertensive medications. Common approaches is to increase the oral doses gradually or adding a new class of oral antihypertensives for better control. Assess the current regimen first, because in most cases it may be due to non-adherence or undertreated chronic hypertension. If the patient is already on medications, uptitrate the dose. For example, you can double the current amlodipine dose from 5 mg to 10 mg, or add a second agent from a complementary class. If the patient is non-adherent, you can restart them on their previous regimen immediately. If the patient has been untreated or has poorly controlled blood pressures, start on combination therapy right away, using two agents from different classes for faster and safer control. The preferred first-line classes per 2025 guidelines are the thiazide-like diuretics, ACE inhibitors or ARBs, or calcium channel blockers. Start with combination therapy for severe cases. Alright, let's arm ourselves with the powerhouse classes of oral antihypertensives. These are the go-to weapons for safely taming hypertensive urgency in the outpatient setting. They are chosen based on patient profile, comorbidities, and response, always starting low, going slow, and monitoring the patient closely. First up in the list are the diuretics, the fluid fighters. They help the kidneys to flush out excess sodium and water, and thus reducing blood volume and pressure. The first on the list are the thiazide diuretics. Examples include hydrochlorothiazide and clothalidone. Next up are the loop diuretics. Examples include furosemide and bumetanide, followed by potassium-sparing diuretics like spironolactone and amiloride. After that, we are going to look at the S inhibitors. These are the angiotensin II converting enzyme inhibitors. They block the formation of angiotensin II and thus relaxing vessels and dropping blood pressure. Examples in this category include lisinopril and enalapril. Next up are their close cousins called angiotensin II receptor blockers. They follow the same pathway, but now they block the receptor directly. Examples include losartan and valsartan. Next up are the calcium channel blockers. They act by relaxing smooth muscle in the arteries by blocking calcium entry. Examples include amlodipine, nifedipine, diltiazem, and verapamil. Next up, we have the beta blockers. They lower cardiac output and renin release. Examples include carvedilol, atenolol, and metoprolol succinate. They are excellent for postmyocardial infarction or with tachycardia. Next up, we have the alpha blockers like prazosin or doxazosin. Start low to avoid fast dose hypotension, and they act by relaxing the blood vessels via alpha-1 blockade. And lastly, we have the centrally acting agents like clonidine or methyl-dopa. They act in the brain to reduce sympathetic outflow, and thus they should be used cautiously. This is the hypertension management pathway for you to follow through as you are going to manage the patients. Pause the video as you have a look at it, as it serves as a very important tool in the management pathway. The first review is done between 2 to 4 weeks, whereby you check for blood pressure response, side effects, adherence to the oral antihypertensives. If the blood pressure is controlled, continue with the same dosage. If the blood pressure is not controlled, increase the dosage or add a second drug from a different class of oral antihypertensives. But medications are only half the battle. Empower your patients with DASH diet, sodium restriction to less than 2 grams per day, physical exercise regularly, weight loss, smoking cessation, and limited alcohol intake. Also consider advising the patients to do home blood pressure monitoring and tight routine follow-ups. You check the patients within 24 to 72 hours, and then you can titrate their medications monthly until they are controlled. And there you have it, the full picture of hypertensive urgency, which is a warning sign of uncontrolled chronic hypertension. No more panic, which leads to overtreatment. Confirm it first through history, physical exam, targeted laboratory tests and imaging studies based on patients' presentation. Manage as outpatient therapy using oral antihypertensives by up-titrating existing medications or starting or restarting the patient on oral antihypertensives, especially for those who are non-adherent. The aim is for slow, safe, and sustainable control below 160 over 100 millimeters of mercury over days. Then target less than 130 over 80 millimeters of mercury blood pressures in the long term. Avoid the old pitfalls of sublingual nifedipine or short-acting agents for rapid blood pressure drops or IV medications, as they can cause tissue ischemia from sudden blood pressure drops. Don't chase the number, but treat the patient. Thank you for watching. Subscribe, like, and share the video.